This is a small village called Rampura, and I'm Rani. This is my mom and dad. I would have had a brother, Sonu, but he died before I was born. He wasn't even a year old when he died. I felt sad when I heard that. My mom got pregnant when she was 17. The health center was far away and she didn't visit a health clinic. She told me she didn't know she had anemia. When Sonu was born, he was as weak as our mom. One day, Sonu developed fever and diarrhea. He was sick again and again. He never received his immunizations. His health got worse. He passed away when he wasn't even a year old. Due to ignorance, no one understood why he died. Sonu is not alone. Did you know that India accounts for nearly 20% of the world's child deaths? 880,000 newborns die during the first month of life, and nearly 1,600,000 children die each year before they turn 5. Health services have gotten better, but not everywhere. I am so lucky because my mom survived. Like many other women in my village, she could also have died during delivery. My mom says a lot of women in my village used to have anemia like she did. And even though they were not healthy, they had babies. Sometimes they would have another baby when their first baby was barely 1 year old. Mostly girls married young and had babies. And many women did not have their babies at the health center. To help people like us, Government of India has started many new health programs. In 2013, India developed the RMNCH+A Strategy. Government is providing services for 5 very important stages of life: newborn, child, adolescent, reproductive, and maternal, because they are all connected. RMNCH+A Strategy is important because a healthy start at birth is essential for a healthy life. And being a healthy mother starts from being a healthy child. That's why my mom could make sure I would survive and grow up healthy. First thing my mom did after Sonu's death was to get in touch with Asha Didi. Asha Didi made sure that my mom wouldn't have a baby when she was unprepared. When mom found out she was going to have me, Asha Didi registered her in a government hospital. She took my mom for health checkups. The healthcare providers gave her iron tablets so she would be strong. Asha Didi took mom to the clinic for delivery in free emergency transport. At the clinic, my mom had a safe delivery. But when I was born, I didn't breathe. But the healthcare providers helped me breathe with a special bag and mask. And then they gave me to mom so she could feed me her milk. I was born early, preterm, like Sonu. But the clinic was prepared and they made sure I stayed skin to skin with my mom. They even had a special newborn care unit for babies who need special care. I received my immunizations to keep me healthy. My mom and dad talked to the healthcare providers about waiting for at least 2 years until she and I were healthy and strong before giving me a little brother or sister. With the help of Asha Didi and the healthcare providers, me and my mom are healthy and happy. I got all of my immunizations. My mom makes sure I eat nutritious food, and when I do get sick or have diarrhea, Asha Didi taught my mom and dad just what to do. The Government of India is also taking many more important steps to ensure that when I grow up, I will not face the same problems that my mom faced. I will be strong and I will not suffer from anemia. My mom and lots of her friends had to leave school, even though the boys didn't. I will finish my studies and I will be able to talk to other young people about staying healthy. I will be able to talk to healthcare providers about my questions and will wait to start my family until I'm ready for it. And when I'm ready to be a mom, my baby will be healthy, just like me. To make sure the RMNCH+A strategy helps mothers and children throughout the country, Government of India created the 5x5 matrix to show all the important programs to keep us healthy. Government of India is making sure to reach all mothers and babies, even in places like my village, which is in a high priority district. Some places need extra help, so everyone can have a chance to have a healthy life. A healthy mother can have a healthy baby, raise a healthy child that will grow to be a healthy adolescent who will one day start a healthy family, a healthy community, and a healthy India. The change has started in India. The future of children like me and women like my mom looks bright.
So namaskar to all of you once again, and wishing you all once again a very pleasant and a happy morning. Indeed, a great pleasure to be given this opportunity to greet and welcome you all this morning on behalf of the Ministry of Health and Family Welfare, Government of India, and on behalf of USAID to the National Dissemination Meeting on MCHIP, the USAID's flagship program, Maternal and Child Health Integrated Program. Thank you indeed for your very distinguished presence, ladies and gentlemen. Now, before we started, as you moved in the hall, you saw a video which was being played. That was an animated video prepared by MCHIP on the request of the Ministry of Health and Family Welfare, and that highlighted the results of the critical Government of India programs which are being supported by MCHIP. Many such videos we are going to be showing you in the course of the day, and they are going to be released in this session. Now, many of you must be aware that the MCHIP program was initiated by USAID in the year 2008. And since then, it has been working in more than 50 developing countries of Asia, Africa, Latin America, and in the Caribbean. And it has been working towards promoting the maternal and child health care. Globally, it has been concentrating on the maternal, newborn, and child health, on immunization, on malaria, on HIV and AIDS, on family planning. And in India, it has been active since 2009. It has been working with the Government of India at the national level and also in various states to accelerate the pace of growth of the various Government of India programs which are towards achieving the Millennium Development Goal 4 and 5. Today's meeting which we have, this is entitled Igniting Change for Women, Children and Their Families. And this is towards sharing the success, the issues, the challenges, and the learnings of these programs, which is a partnership between Government of India and MCHIP. And based on these learning, then deciphering the way forward. So once again, thank you to all of you for joining us in this exercise and for your contribution and support. Now, before we actually take a deep dive in understanding more deeper the 4 thematic areas of the MCHIP program, we first present to you the overview of this entire program and the vision, the mission, the policies behind it, the views and the opinions of the torchbearers and the supporters of the program. So let me take the opportunity of inviting the distinguished speakers of the inaugural session here on the dais. Please join me, ladies and gentlemen, in inviting Mr. C.K. Mishra, Additional Secretary and Mission Director, National Health Mission. Pleasure to be joined by Mr. John Bede, USAID Mission Director, inviting him here to kindly grace the dais. Dr. Rakesh Kumar, Joint Secretary, RMNCH+A. Inviting Mr. Manoj Jhalani, Joint Secretary, Policy. Inviting Dr. Bulbul Sood, Country Representative, MCHIP. May now request and invite Ms. Patricia Taylor, MCHIP Country Support Team Leader. And pleasure to welcome Dr. Rajesh Singh from MCHIP. Thank you and welcome to all of you. And at the outset, now we try understanding the MCHIP program in India. Again, the vision, the mission which is behind it. So for that, I would like to invite Dr. Bulbul Sood, Country Representative, MCHIP, for presenting an overview of the MCHIP program and also for her welcome address.
Good morning, friends. Mr. C.K. Mishra, Additional Secretary and Mission Director, National Health Mission. Dr. Rakesh Kumar, Joint Secretary, RMNCH. Mr. Manoj Jhalani, Joint Secretary, Policy. Mr. John Bede, Mission Director, USAID. My colleague from MCHIP on the dais, mission directors and invited guests from several states, donor partners, and distinguished guests, ladies and gentlemen. On behalf of Government of India, Ministry of Health and Family Welfare, and MCHIP, it's my proud privilege today to have you today with all of us for the end of project dissemination meeting of the USAID flagship Maternal and Child Health Integrated Program. Thank you very much for coming despite your very busy schedule. We at MCHIP feel privileged that we got an opportunity to work with the Government of India at national and state level, and that we have been able to ignite some of the changes which are going to make a lot of difference to millions of women and children in this country. It's hard to believe that it's only 5 years back we started this work. And I was thinking, what has MCHIP done in the last 5 years? We collaborated with Government of India at national and state level, and in their efforts to achieve the MDG 4 and 5. And I think that is the collaboration which is showing the results, and we see the changes already happening in the MDG goals. We also gain insight on how to, do things in a way that you can make impact at scale. And I'm happy to share that some of the learnings in India are now being used extensively in other countries in the region, and within the country. And also, we learn how to leverage the talents of multiple partners, work together in a collaborative manner. If you look at the MCHIP priorities globally, it is to ensure country ownership. And this is what has happened. You can see that invitation has gone out as a joint invitation from Government of India and MCHIP. We also took the high impact intervention to scale, and today in the day of the, you will hear how things have been scaled up within the country. We have created changes to global and regional influence, and again, we would be sharing how these global changes, today I think is one word, We don't wait for things to happen, wait for a dissemination meeting after 5 years. Things are shared very quickly. And we've been also looking at, what is happening with, all the intervention. Is it making an impact? And measuring, and looking at the data and making decisions based on data. And expanding coverage through integrated approach, which RMNCH+A is one very successful integrated approach that the Government of India has now scaled up in the entire country. MCHIP is a consortium of 8 partners and led by JPIGO. In India, it was JSI, Save Children and JPIGO which worked together, and we provided technical assistance. MCHIP has worked in more than 50 countries, and you must be wondering why I'm showing you this slide. The reason is that, again, there was immense sharing of experience across the countries, and before the end of the project, a lot of things have been, adapted in different countries. For example, when we started the success of postpartum family planning and introduction of PPICD, we shared, and immediately it was scaled up in several African and Asian countries. Rapid is another example. When we started, and similarly the learnings, for example, when we started strengthening the nursing education, we looked at the experience of Afghanistan, where things had started in 2002-3, and very quickly adapted the educational standards, and we didn't took long time to, because adaptation is very quickly rolled out, and misoprostol, so several experiences were there. MCHIP started work in UP, Jharkhand and Uttarakhand, and for first 3.5 years we were only concentrating in these 3 states, and of course also at the national level. But later on, when RMNCH+A was launched, we expanded into other states. So now we are working in the 6 USAID focus states, which are, as you know, Jharkhand, Uttarakhand, Haryana, Punjab, Himachal Pradesh, and Delhi. MCHIP in India has used a life cycle approach. So we have been working from the intervention from the pre-pregnancy to under 5. So it covers gamut of activities. And we have been collaborating with the Government of India in, I would say, mainly the 5 areas. One is on strengthening the routine immunization. The other area is on strengthening the nursing and midwifery cadre. We started with the pre-service education, but we realized we have to actually, strengthen the entire cadre to get the desired effect. Strengthening of the newborn care, also strengthening of the postpartum family planning, and in fact, introduction of postpartum IUCD. And then last but not least, most important, the child survival call to action, initiation and rollout of RMNCH+A. Again, the technical assistant expanded from the national level down to the state, to the district, and also the, in fact, sub-district level. So we worked with the government on several advocacy issues, on influencing the national policies, strategies, but we didn't stop there. We, in fact, most of the time I get, so what? We have very good policies. How to operationalize it? And I think we work together to operationalize and demonstrate how it can be done in a systematic manner, building the capacity of the system, and also improving planning and monitoring, both at the state, at the district, sub-district level, and creating demonstration sites, creating state nodal centers. And I think that is what has, triggered a dominoes effect where now it has been scaled up extensively. So what? What has been the MCHIP contributions? And I can just say, briefly that it has significantly contributed towards MDG 4 and 5. And in fact, in the material that you have been provided, you would see this is part of the MCHIP dissemination meeting folder, and you can see what we have contributed in that. We worked on several policy initiatives to support the RMNCH+A. I would say first one was, in fact, an entire family planning, which was seen more as population stabilization, to move from family planning to a RMNCH+A initiative with increased focus on spacing. And I'm glad to say that that learning has now been, scaled up, as I said, in several other countries. Task shifting was another area we worked from, for example, for the especially PPICD, from doctors moving to the nurses and having a dedicated counselor at these sites. The other policy area we worked was to develop a roadmap for strengthening the nursing and midwifery cadre, and I'm glad to say it's already working in more than 10 high-focus states in the country. Another policy shift was advanced distribution of misoprostol by ASHA for the prevention of PPH, and this again is, now being, we completed the field testing, and it will be rolled out in the places where it is needed. Use of chlorhexidine by A&M for the newborn infection, and also use of antenatal corticosteroids by the auxiliary nurse midwives. We have contributed in several of the Government of India guidelines, whether it was on the RMNCH+A strategy development, or whether it was on the MNH toolkit, on the roadmap for the government. And as you can see, everything is now approved and vetted by the Government of India, and it's being used all over the country, shared extensively. Similarly, we worked on developing training materials, the training of manuals for the trainers, for the providers, and again in the area of family planning, for the nursing education, for the counselors, for the essential newborn care, and misoprostol. So you name it, and they have been now again also translated in several of the languages of the country. A lot of IC material, BCC material has also been developed, used extensively, translated in several Indian languages. So I would like, in the end, just say, what are the success factors? There was a Government of India commitment to ending child and maternal death, EPCMD, and you will hear more when John talks about it. There was a government investment at national and state levels for the scale-up of integrated services. And in most of the, when scale-up, it was NHM funds which were used to, take it forward. And then, last but not least, most important, that there was a supplemental donor support to accelerate scale-up of high-impact intervention. So as I said in the beginning, this was definitely a collaboration which has shown the success. And I'm, again, very grateful to the Government of India for their constant support, guidance, and encouragement. Thank you very much.
Thank you, ma'am, for the overview of the MCHIP program. So the scope has been huge, the outreach has been vast, and the program has been able to make an impact, and the change is there for everyone to see. So we now try finding out from Ms. Patricia Taylor, who's the MCHIP Country Support Team Leader, her views on this partnership with the Government of India, and again the impact which these programs have been able to make. Inviting Ms. Patricia Taylor.
Thank you so much. Good morning to all of you, and warm greetings from our worldwide MCHIP colleagues, officials of the Ministry of Health and Family Welfare and the National Health Mission, state delegations, mission directors, USAID representatives, representatives from our development partners and other organizations of the country, dear colleagues, and ladies and gentlemen. As Dr. Bulbul mentioned, Since MCHIP was created or established in 2008, we worked in over 50 countries. A little known fact is that one of the first USAID missions to put funding into MCHIP, to the MCHIP agreement, was USAID India. We were very grateful at the time for that. We had very few countries actually that bought in the early days of the project. But what it means is that India was one of our first country programs, and it's actually, as we go into the final months of our 6th year, it will be one of our longest running programs. It's currently grown tremendously, frankly, from where it started. We're very proud to be part of it, and we've been excited by the partnership with the Ministry of Health and Family Welfare in particular, and with the states where we've worked. MCHIP was originally funded, I should just mention, we were originally funded to continue work of the earlier USAID flagship programs. Many of you may have heard or remember the Access program that worked on maternal and newborn health, and the basics and the immunization basics projects that worked on immunization, but also other aspects of child health. Since that time, our mandate has increased almost every year. And during our first 3 years, as Dr. Bulbul mentioned, we really focused on 4 strategic objectives, very specific technical objectives that looked at strengthening the universal immunization program and the quality of routine immunization, revitalizing postpartum family planning and introducing the PPIUCD, improving the quality of care for newborns both in facilities and at community level, and strengthening pre-service education of nurses and midwives. Then, in late 2012 and early 2013, shortly after the Global Child Survival Call to Action meeting in Washington, D.C., that was hosted by the government of India jointly with the government of the United States, the government of Ethiopia, and UNICEF, the Minister of Health decided to, in fact, proceed with a national summit on the call to action for child survival here in India. And MCHIP had the privilege of serving as the secretariat for that national meeting during those late months of 2012 and early into 2013. As I think you all know, that historic event took place in February of 2013 in a place where I always mess up the name, so you'll excuse me, but Mahabalipuram, Tamil Nadu. And it was there that the government of India launched the Reproductive, Maternal, Newborn, Child, and Adolescent Health Strategy, the new strategy, and a number of other key documents. Very shortly after the national summit, the government, the Ministry of Health in particular, requested the support of all of its health sector development partners to help roll out the RMNCH+A strategy. And it was at that point that USAID was asked to support at national level and also in 6 of the country's 29 states. And they came to MCHIP and asked us to help lead the implementation process in the 6 states and at national level. And we were very pleased and also humbled, actually, to be asked to do this. But since that time, we haven't given up our technical focus. We still work on family planning and immunization and newborn and pre-service education. But since that time, our focus has really changed to actually intensively helping the government of India roll out the RMNCH+A strategy in the 6 USAID states that Dr. Bulbul also mentioned. It's incredible to think that that was only 15 months ago, because so much activity has actually been packed into such a short time that it feels like it was a long time ago. But it was really only 14, 15 months ago. And it's been very exciting for us, actually, as a global team and also for the India team, speaking for them. It's been very exciting to be part of this effort. As the Director of Country Programs for MCHIP, I can tell you that we are very proud of all of our country programs and all of our country teams. But I also have to tell you that I have a soft spot, and I think others in this audience do as well from MCHIP Global, for this team. There's something special about the team, there's something special about the partnership with the Government of India, and there's something particularly exciting about the Government of India's leadership and initiative around this current RMNCH+A initiative. The remainder of our presentations in this inaugural session are from the government, and from our keynote speakers, from USAID, and most of them will focus somewhat on RMNCH+A. So I'd like to kick off the rest of this inaugural session by showing a short video that MCHIP and USAID have produced recently to celebrate the extraordinary leadership of the Government of India in rolling out the RMNCH+A initiative and all the other programs that are really part and parcel of it. So without further ado, let's watch the video.
Year-old Chitralekha resolutely heads to this community health center in Sadhaura in Haryana state. Her 3-year-old daughter Akshita has been suffering from sore throat, cough and vomiting for over a week. She is attended by a doctor. It has saved her mother a long bus journey to neighboring Ambala and a hefty consultation fee.
जैसे ही आती हूँ पर्ची बन जाती है और साथ के साथ दवाई मिल जाती है और अगर कोई थोड़ी बहुत बीमारी होती है वो हम सब सेंटर चले जाते हैं, वहाँ एएनएम बहन जी होती है उनसे दवाई ले लेते हैं। और कई बार तो घर पे आशा वर्कर आती है, जैसे बच्चे को वोमिटिंग हो रही है जैसे तो मतलब उल्टी वगैरह में वो हमें बता देती है कि आप इनको ORS घोल पिला दो, तो वो पिला देते हैं, तब भी आराम आ जाता है।
Fair and equal access to healthcare services had once been unthinkable for socially disadvantaged and marginalized women in India. The country's health indicators put in perspective the story of its maternal and child health conditions. India accounted for 19% of all global maternal deaths in 2010. In India, every year, over 300,000 babies die at birth and around 1.45 million children die before their 5th birthday. To address this problem, India co-convened the Global Child Survival Call to Action, a Promise to Keep summit. The summit posed a fresh challenge to the world to reduce child mortality to below 20 child deaths or fewer per 1,000 live births in every country before 2035. The then Union Minister for Health and Family Welfare, Shri Ghulam Nabi Azad, reiterated India's commitment to bending the curve on child mortality and morbidity. The Government of India kept its promise, pledging its highest ownership and prioritization to this goal. In 2013, the Government of India held its own national summit on the call to action for child survival and launched a new, holistic, reproductive, maternal, newborn, child and adolescent health strategy known as the RMNCH+A Strategy.
RMNCH+A, which does a number of things for the first time. One is that we said that there are strong interlinkages between sets of interventions that we have been talking about and pursuing really very independently in vertical silos. For instance, we have been talking of family planning as more as a population stabilization strategy, but we did not really look at it as a critical health intervention to improve outcomes for mothers and children. So now we repositioned family planning as a very, very strong way of making sure that less mothers die and less children die in India.
USAID as well as other development partners have worked closely under the leadership of the Government of India to support the call to action and the RMNCH+A strategy nationally. MCHIP has provided technical assistance to the Government of India at the national level and in 6 states as USAID's lead RMNCH+A partner.
The biggest strength of MCHIP is to work very closely with Government of India and state government. We worked very closely on a day-to-day basis. MCHIP provided several pieces of support under this RMNCH+A rollout. We provided support and we helped the Government of India in the selection of high priority districts.
Though the RMNCH+A strategy was launched in 2013, results are already visible. For 30-year-old Pinky, with 2 young children and expecting her third, home visits by accredited social health activists, popularly called Asha Behenji, ensured that Pinky was given the right guidance.
मेरे पास आशा बहन जी वर्कर आती हैं, वो मेरे को सलाह देती हैं भी खाने प्रेगनेंसी में क्या खाना चाहिए, अंकुरित दालें। आशा वर्कर मेरे बहन जी मेरे पास आई थी पहले भी टेस्ट कराना है, हमने टेस्ट किया, मेरे 3रे महीने में चेकअप हुआ, एक 5वें में और एक 7वें मंथ में चेकअप हुआ। अभी एक चेकअप रह गया है, 9वें मंथ में होएगा।
Frontline health workers, including Ashas, auxiliary nurse midwives, nurses and doctors are providing integrated services to women and children throughout India. Through effective community mobilization, Ashas and auxiliary nurse midwives make it possible to link health services provided in the home with those provided in health facilities. They in turn gain from intensive support supervision, on-site training and mentoring to enhance and optimize their knowledge and skills.
एक रैपिड टीम आती है यहाँ पर और हमें तरह तरह के प्रशिक्षण नवजात शिशु के बारे में और मदर के बारे में बताकर जाती है। उससे पहले जो हमारा स्किल लेवल था वो बहुत ही पुअर था और हम जिससे कि मदर को भी इन्फेक्शन होने के चांसेस होते थे और बेबी को भी। ये हमें प्रैक्टिकली डमी पर बताकर जाते हैं, उसके बाद हमारा फॉलोअप भी लेते हैं, उसके बाद हम उसको डेली रूटीन में उसी तरह से मेंटेन कर रहे हैं। इसके बाद जो हमारा इन्फेंट मोर्टेलिटी रेट है और मदर मोर्टेलिटी रेट है वो बहुत ही कम हो गया है।
The quality of health services is crucial to the success of the RMNCH+A strategy in high priority districts. To significantly improve the survival of mothers and children, they must have access to good quality health services.
There are 3 critical and important components which we are doing with MCHIP. First is relating to the quality of cold chain points. Second is relating to the essential newborn care facility readiness assessment. And finally, we are doing the intrapartum and immediate postpartum modules which are helping us to improve the quality of services.
A strength of the RMNCH+A strategy is that it communicates using easy to understand technical documents, state-specific scorecards and dashboards. The 5x5 matrix has become an important training and management tool. The matrix lists proven health interventions at 5 important points in the lives of women and children: pre-pregnancy, pregnancy, labor and delivery, early childhood to age 5, and adolescence. The gap analyses carried out in each state as part of the RMNCH+A rollout revealed ways in which the quality of care for all women and infants could be improved. Like at this maternity home in Selampur in North-East District of Delhi, young mothers line up to get their newborns vaccinated. An auxiliary nurse midwife instructs them on breastfeeding while another counsels antenatal care patients. The government's efforts at the highest policy level and the critical role of development partners like USAID have resulted in a robust model for expanding the reach, quality and outcomes of government health services for women and children. One that is inclusive, participatory and continuously evolving.
I think the most impressive shift that I've had the opportunity to see is really kind of a very close alignment and harmonization of the kinds of technical expertise that's being brought in, other international models, and also taking the best of of what India has to offer, which is quite substantial in the area of innovation, whether it's medical technology or really a much more robust system of monitoring and accountability in terms of public health sector delivery.
The Government of India is committed to protecting the lives and health of women, children and adolescents through the RMNCH+A strategy through a continuum of services, constant innovation and routine monitoring. USAID is committed to working with and under the leadership of the government to ensure that India achieves the goal of ending preventable child and maternal deaths. The eyes of the world are now on India.
So the eyes of the world are now on India, and I think this video spoke for itself, how impressive and how impactful this partnership has been. Now, ladies and gentlemen, as you saw in the video, reducing maternal and child mortality has been one of the most important goals of the National Health Mission. And towards that, realizing that a very cohesive approach is going to be required, a clear articulation of the strategic approach to reproduction, newborn, child and adolescent health, maternal, that is RMNCH+A, was designed by the Government of India. So as to now present to you the national perspective on it, may I now invite Dr. Rakesh Kumar, Joint Secretary, RMNCH+A.
Respected Additional Secretary and Mission Director, Mr. C.K. Mishra, my senior colleague from the Ministry, Mr. Manoj Jhalani, who is Joint Secretary Policy, Mr. John B., Director, USAID India Country Office, Pat Taylor, Dr. Bulbul Sood, Dr. Rajesh Singh. I can see Koki, I think he flew all the way from Washington to this place. I would say that I am able to see almost each and every stakeholder who is participating here, from whether it is reproductive health, maternal health, child health, newborn, or family planning. So I'm extremely happy to be here this morning. I did not know what exactly I was supposed to talk about today. I discussed with Dr. Bulbul. I said RMNCH+A is such it's a strategy, and see, I can say if we start talking and discussing about this, it might take hours together. Nevertheless, I've tried putting up together a few slides. At the outset, I would also like to compliment MCHIP, for their, I would say, an outstanding performance they have really shown over the past 5 years. We worked very closely with MCHIP. I distinctly remember Dr. Bulbul Sood, Dr. Karan Sagar, who's now gone to Gavi, Rajesh Singh. We worked together day in and out. We started working on this concept of RMNCH+A. Finally, in February 2013, we came out with this strategy. And certainly it has been able to ignite those kind of changes. So I think we have no doubts about it, about the success of this initiative. And finally it is coming to an end. And during the day's deliberation, we hear more about what exactly has been implemented in the field. Friends, when we talk about RMNCH+A strategic approach, I would like to just take you through the kind of historical journey which India has really traversed since 1947, I think, exactly about 67 years back from now. We started our journey with a very heavy burden. Our population was 35 crores, with a TFR of 6 in 1947. Our maternal mortality ratio was 2,000 per 100,000 live births. IMR was 162, again one of the highest in the world. If we look at the numbers, I'm talking about total mortality. 50% of the total mortality used to be less than 10 years of age. Our life expectancy was as low as 32 years, 33 years. So since 1947 and as of now, you can easily make out that we have grown really big in size. If you look at our population, we are 1.24 billion. Our TFR has certainly come down, it's 2.4. If you look at our under 5 mortality, this is 52, 1,000 live births. IMR is 42, 1,000 live births. Maternal mortality, certainly I think we have shown those kind of strides. It has come down to 178. And I don't really see any reason that India does not really achieve MDG 4 and 5. And I'm really very confident because we all stakeholders are here today. And I would like to take this opportunity, I mean, certainly because you're all there, that we must resolve today that now as we are left with only 500 days to achieve MDG goal 4 and 5, I think let us, start working together with more rigor and more on the field. If we look at India's global burden in terms of contribution, as I said, we contribute to nearly 18% of the total population of the world. We share about 2.4% of the total, I would say, land size in the world, but look at the population, 18%. Childbirth is about 1/5 of the world, is about 20%. Newborn deaths, one of the highest is 28%. I think this is certainly cause of concern for us. Under 5 deaths is 22%. Maternal deaths, which used to be about 27%, that was, I'm talking about, 4 or 5 years back, it has come down to now 16%. And we talk about extreme poverty, then 33% of extreme poor in the world that live in India. So certainly I think this is also one of the important factors. I thought let me just remind you about what are various causes of maternal deaths. We always talk about those medical causes. We mostly are doctors, so we always tend to look at the medical causes. We say that PPH or the hemorrhages, it's about 38% is the cause maternal death. Sepsis is about 11%. Hypertensive disorders, we talk about eclampsia and preeclampsia, it's about 5%. Obstetric labor is 5%. Abortion is 8%. But look at other conditions. Anemia directly contributes to nearly 20% of total maternal mortality, and indirectly about 50%. So my point here is that the other reasons, they play an important role. And we always land up, I said, just investigating into the medical causes, but more important for us as program managers is that you must have a look at those kind of 3 delays. The first delay being the delay in decision taking. I mean, there's always a delay in making a decision whether the patient needs to be referred to a facility or not. Second is about once we take the decision, then the delay in ensuring that the patient or the mother reaches the hospital. So again, this is the second delay. And third, and I would say very important delay, which we always tend to forget, and we always take that if the patient reaches or mother reaches hospital, she would immediately start getting attention and the treatment, which generally we don't really get. So I think this is very important. And I think the program managers, from the state governments, at the national level, we need to now start looking at these kind of delays. When we talk about maternal death, then socio-economic factors, they play a major role. We are talking about early pregnancies, let us say early marriage, it's an important factor in our country. So early marriages, early pregnancy, frequent childbirths. So ultimately, we will end up finally in those kind of maternal deaths. We look at the number, it's very mind-boggling. It's of 1.8 million teenage pregnancies in the country. And it is an established fact that if between 15 to 19 years, if the mother delivers a baby, then chances of her dying becomes 5 times. Between less than 20 years is about 2 times. So certainly I think less than 15 years is about 5 times, and less than 20 years is about, between 19 and 20 years is about 2 times. So certainly I think this is very important for us. If we are able to delay the marriages, this is going to really make a difference in the total mortality in the country. If we look at the progress, then certainly India has made those kind of strides, and certainly we have been able to achieve better than the global average. In 1990, the global average was 380, which has come down to 210. India's 1990 MMR is taken as 560, which has come down to 178. In terms of percentage decline, 45% global and 68% Indian countries decline. Certainly, we have done much better. In 1990, we used to lose about 1,49,000 mothers every year, which has now come down to 47,000. Certainly, it's a tremendous achievement, and the credit goes to all of you and the people who are really implementing in the field. These are, the important causes for under 5 mortality. You've seen the picture, I think. We always say that we lose about 1.4 million under 5 children in the country. And on the very first day, 3 lakh. So 3 lakh on the very first day, I think certainly, we can't really take it so kindly and so easily. Why a child or baby should really die? And we look at the major contributors, 52% is newborn mortality. International data says about 56%. 23% is because of pneumonia, and about 13% because of diarrhea. I think pneumonia and diarrhea, we're trying to target. These are the low-hanging fruits. Friends, we really need to work very hard. Simple solutions like availability of ORS and zinc in the field can really make a difference. We lose about 2 lakh under 5 children because of diarrhea in the country. I think it's a shame on us. How can a child die because of diarrhea, where the life can easily be saved by simple solutions? Similarly, for pneumonia, we lose about 3.5 lakh children every year because of pneumonia. And again, simple solution, community-based management of pneumonia is very important. I think, friends, somehow we have lost the focus on these, I think, the community-based, managed kind of sickness or illnesses. So let us try to focus on pneumonia and diarrhea. Pneumonia and diarrhea put together is it's about 40%. We can easily save these lives. And similarly, on newborn side, I always say that's about 52%. We have been able to make those kind of, I would say, strides and those kind of progress in the country, and thanks to our facility-based newborn care, which has really gone up like anything. Currently, we have about 525 special newborn care, facilities which have been established at the district level in the country, and this is really making a difference. But again, at the same time, our home-based newborn care is poor. Let us, friends, start focusing on home-based newborn care, because home-based newborn care done properly can save nearly 25% of total newborn mortality in the country. So I think we know the evidence is always there, so let us start focusing on these 2 areas. So newborn mortality, pneumonia and diarrhea put together contributes to more than 80% of the total, under 5 deaths in the country. So I think if you just focus in these areas, we'll be there. This is the progress, MDG4. One can easily make out. In 1990, our under 5 mortality was 126, which has come down to 52 in 2012. If we look at the compounded annual rate of decline, this is about 3.9%. This is the average. But you see, between 1990 and 2008, the decline was just 3.3% only. But look, between 2008 and 12, after NRHM started really, working on this, after 2008, the kind of decline has been, it's about 6.8%. So NRHM has certainly made those kind of difference in the country. So friends, I think if you are able to sustain this kind of decline, in the next 500 days or so, I think we should be able to achieve MDG4 as well. India is certainly slowing down. I said started at 6 DFR of 6 in 1947. It has now come down to 2.4. 48% of the total population has been able to decrease or have been able to achieve the replacement level of TFR. 10% is again within the reach. I think we should be able to achieve that. But 42% again, like you look at states like UP, Bihar is 3.5 TFR, UP is 3.3, Rajasthan is 2.9, Madhya Pradesh 2.9. I think we need to focus in these 4 particular states. And we are talking about RMNCH+A. It's just simple, one can easily relate the TFR and the maternal and newborn mortality. These are the 4, I would say, the highest burden in terms of morbidity and mortality in the country, these 4 states. As I said, Bihar is 3.5, UP is 3.3, and Rajasthan and Madhya Pradesh is 2.9. And look at the total mortality. If these 4 states put together, the maternal mortality is about 2/3 of the total mortality in the country. And UP, Bihar put together is 50% of the total maternal mortality comes from these two states. Similarly, these four states, UP, Bihar, Rajasthan, Madhya Pradesh, the total under 5 mortality is more than 50%. And I think we can easily correlate, with the TFR, the kind of, the family planning services we have in the country. We all know that in June 2012, there was a global call to action, which was held in Washington, D.C., India, Ethiopia, and USA were the co-hosts. And India, at that point of time, when Honorable former Minister, he went there, he made a commitment over there. The purpose was to raise the global awareness for child survival, to bend the curve on child mortality, focus on special requirements of vulnerable marginalized populations, and to prioritize convergence of child survival services and universal health coverage. After that, we had our call to action, which was held in Mahabalipuram. This was call to action on child survival and basically on development also. So we added another dimension. It was not only child survival, but development also. So that was held in February 2013, between 7th and 9th of February at Mahabalipuram. And then finally, recently we had this call to action. Basically, this was acting on the call. The second year, basically, it was celebrated in Washington, D.C. The current Honorable Minister, Health Minister, Dr. Harshvardhan, he participated on behalf of our country. India co-hosted this event also. And again, it was a sort of resolve that India made that we would be able to, work towards reducing, or we'd be able to achieve those MDG 4 and 5. We talk about, and during the Mahabalipuram, this call to action, RMNCH+A strategic approach was basically adopted by the country. And you all know, I need not to really go through the details, but basically it's a continuum of care approach. We say that the care must begin in pre-pregnancy. So care starting in pre-pregnancy, whether it is adolescence, pre-pregnancy, during the pregnancy, intrapartum care, newborn care, then young children up to 5, and then adolescents, basically focus on adolescents. So why +A? As you all know, plus is basically India is trying to lay more emphasis on adolescents because they are the future parents. And the second dimension of continuum of care was basically linking the communities with the facilities. So basically, this is the continuum of care approach. Friends, this is not something new, but ultimately, I think this reminds us that we need to work, in such a fashion that each life stage of the human being, gets equal kind of attention. These are the key features, like health system strengthening is the important thing. We need to improve on the infrastructure, human resources, drugs and commodities, referral transport, prioritization of investments. We all know that we have identified 184 high priority districts in the country in the tribal and marginalized pockets. Then 5x5 matrix has also been shared with you. I think everybody of you are aware about this. Then there's also a list of essential commodities in each life stage. Then we need to have integrated monitoring, accountability, and convergence and partnership. I said, beyond health sector interventions, they also play a major role. I said the girls' education, the nutrition component, they play a major role. So look at the hygiene and sanitation. So multiple stakeholders, including multiple ministries and departments, they need to really work together. This is a 5x5 matrix. This has already been shared. This is what basically your 184 high priority districts. As you all know, these 184 high priority districts were identified based on a composite health index, which was applied. Basically, 2 indicators were taken from maternal health, 2 from child health, 2 from family planning. This composite health index was then finally applied to the districts, and it was decided that let us identify lowest 25% districts in each state. So therefore, you'll also find high priority districts in Kerala, in Tamil Nadu, Maharashtra, who are the better performing states in the country. And I'm extremely happy to share, because you are the partners sitting here, I'm also grateful and thankful to you all that ultimately you took a lead, you became lead partners in the states and started working with the state governments and the national government. So I think the different colors, they depict, the presence of development partners in the country in high priority districts. So I said, if you ask from me, then I think the call to action, though we had call to action in 2012, but from India's point of view, I think the real call to action was National Rural Health Mission, which was launched in 2005, because it brought in resources for the country. In 1992, when CSSM was started, you all know, it was mostly the programs. You know, we started talking about child survival, maternal survival, and then continuum of care. So continuum of care has not been, it's an old kind of, you know, I would say, it's statement which are really made. But I think the real call to action really started when NRSM brought those kind of resources. Then we had this global call to action, India's call to action. In April 2013, friends, I distinctly recall I made a presentation about the national, we conducted a national consultation which was hosted by MCHIP. And we sat with the development partners and we worked on a roadmap that how exactly, because this is a concept, we need to have a roadmap to work together. After, you know, then in May 2013, we had our first state level consultation that was held in Rajasthan. I think that was on 10th of May also. So the first consultation was held in Rajasthan. And then we had series of consultation with all the states. And we have about 29 state level consultations in the country. So 1 year has been full of orienting state level people, district level people, as a huge work which was conducted in the last 1 year. And then 2014, as I said, there was Acting on the Call conference which was held in Washington, D.C. So friends, the progress in 1 year has been tremendous, I would say, unprecedented. We have been able to put in those kind of structures. I said we are able to define those TORs and the way forward. We identified 184 high priority districts. In certain states, they went further. They identified high priority blocks, like I can distinctly recall Gujarat and Maharashtra, they are working on high priority blocks. Then we sought your partnership, I mean harmonized technical assistance and managerial assistance from 6 development partners, UNICEF being the largest one in 17 states, followed by USAID in 6 states. So similarly, you know, we have partners too. DFID is in Madhya Pradesh and Orissa. Similarly, we have USAID, I said, in 6 states. UNFPA is in Rajasthan, UNICEF in 17 states. So this is how, you know, we have been able to spread out ourselves in 29 states in the country. The plans have been drawn. The high impact interventions have also been identified. NRU was established. SRUs at the state level, they were established. District level monitors have been put in place. And various operational guidelines, as Dr. Bulbul Sood was projecting this. I think we had plenty of, you know, guidelines which have been prepared in the last 1 year. And the gap analysis for high priority districts were conducted. So basically, these were the kind of, I would say, major activities which were conducted. So therefore, a lot of ground has been covered, but I would like to just share, because friends, we can't really afford to be complacent about this. On this occasion, I would also like to remind you that this kind of work which we have been able to establish till now was a kind of easier course for us. We were able to, you know, bring out those kind of guidelines, operational guidelines. We had consultations sitting in 5-star hotels and all. But the real work starts now. And whatsoever, you know, information I have been able to gather from these DPs and through these district level monitors, these are the kind of observations I thought I must share with you. So DPs are present in all the districts, but the progress is uneven. There's inadequate orientation of district level monitors, because ultimately they are the people on the field, on the ground. We need to orient them. There's irregular review meetings which are being conducted at the state level and district level. We need to really regularize these meetings with the state level, with the state MD, NLs and principal secretaries, and the district level, district magistrate and chief medical officers. There's a weak mechanism for follow-up on corrective steps. I think unless we follow up on the corrective steps, I think, you know, finding gaps is one thing, but getting them corrected and having a follow-up is very important. The quality of data needs urgent attention. You are here, I can always share with you. I have seen reports where the district level monitors, you know, they have faked the data. I think this can't really happen. This can't be a business as usual. So I would just request you that the quality of monitoring needs to be, you know, of high quality. There's a poor analysis at the state level by SRUs. We need to collect, collate, analyze, and then start working. There's a poor coordination with the districts and the state level functionaries. We need to have better coordination, you know, at the state and district level. Gap analysis has been conducted, but in many cases, you know, it has not really been incorporated in the PIPs. I've seen, certain DPs who are trying to innovate in their own ways, and we are not really aware about this. I think this is not really going to work. I would request you that innovation is fine, but let us sit down, let us decide and discuss, and then we start innovating on this. We need to focus on hardware. I think our focus is mostly on the software. Hardware is the key. Unless you have hardware in place, software is not going to work, friends. So I think we need to be really, hardware oriented. We need to also make these medical colleges participate. Therefore, the concept, as I said, has already existed, and certainly it is not a program. It has successfully reminded us of the continuum of care approach. I think that's the first thing. Second is that why high impact interventions, each life stage, are crucial for maternal newborn care. I think for the first time, the program managers and experts, we are convinced that, okay, life cycle approach is very important. We have been talking about this, but till now we are not really very much, practicing this. But I think we know that family planning is very important. We know adolescent health is very important. It is not only maternal health, newborn health and child health, which is going to basically ensure survival of mothers and children in the country. We need to focus on implementation of high impact interventions. I think this is high time. We need to, and that too equally, as I said, equity is a major issue. We need to work in tandem with each other. There are multiple departments, many stakeholders, and certainly we need to work in coordination. Therefore, this is my second last slide. We need to be firmly on the ground and on the field. We need to focus on high burden areas and pockets. Secondly, we should not really digress from the very basic interventions. In the process, we tend to forget about the very basic interventions like IYCF. We need to have, early initiation of breastfeeding is extremely important, but how many of us we really talk about this? Similarly, exclusive breastfeeding of 6 months is very important. Complementary feeding, that too adequate and of quality with hygiene is very important. Hand washing and hygiene is very important. Diarrhea setting in at the age of 6 months to 11 months is simply because we start off with the complementary feeding, but with unhygienic conditions. That's why the child suffers from diarrhea. Similarly, the kangaroo mother care is very important. Community management of diarrhea and pneumonia. I think we are focusing more on facility-based newborn care, but I think in the process, we have forgotten these big killers like pneumonia and diarrhea, which can be managed in the community. Then very basics of antenatal care. Antenatal care, I think quality is somewhere missing. I'm looking at DLHS-4 data, which has now started coming into, but the quality is very poor. Look at the BP, not even 50% of the cases, the BP is being measured. Hemoglobin, not even 60, 70%. Where is the quality? I think this is very important. We need to focus on postnatal care, home-based newborn care, and let us say routine immunization. So these are very basic, I would say interventions. We should not really, forget these interventions. Then we need to invest in staff nurses, ANMs, ASHAs and Anganwadi workers and the related systems and institutions. What we have been thinking, I think basically they are the people who are going to save our newborns and the mothers in the field. It's not the doctors. We need them only in 10% of the cases, not more than 10 to 15% of the cases. But in majority of the cases, basically these are your staff nurses, frontline workers. Basically they are our soldiers, foot soldiers, we always call them. I think we need to focus on them. We need to, make them so prominent. We need to, provide them respect, care, affection, and dignity. I think that is going to work. Friends, as I said, we need to roll out these high impact interventions. I think we need to work on this. We have many, I would say, we have now countless operational guidelines. At least I'm not able to count them. But ultimately, that is not really going to work. We need to now start implementing these guidelines in the field. We need not to develop any more, actually. I can always say, recently we have also, taken a policy decision. I said, we already taken a decision about gentamicin used by ANMs in sepsis cases, antenatal corticosteroids, already taken preterm labors, kangaroo mother care, vitamin K injection, misoprostol distribution for PPAs in home-based care delivery. There are few more like on quality. We are talking about calcium supplementation during pregnancy, screening for cancers like CA breast and CA cervix. It's also we are working the guidelines. Similarly, hypothyroidism during pregnancy, gestational diabetes. So we have already, we have almost finalized those guidelines. But I think this is high time that now we start basically getting them implemented. effective coverage, my Medicine Secretary always talks about quality. I think we have numbers, India has got numbers, but quality improvements is most important for us now. So we work, so all the implementations, any implementation has to be of quality. So effective coverage has to be there, and supportive supervision visits, I think, so that we keep on monitoring and supervising. We keep on taking simultaneous corrective steps also. And awareness generation, I think this is also one of the weak areas, that how best we can improve the awareness for improved health-seeking behavior. So friends, I said we are left with about 500 days now, and if you are talking about achieving MDGs, then certainly we need to go to scale. That is the first thing. The quality has to be there. All the interventions have to be implemented with quality. And an equity-centric planning is going to really work for us. And I'm sure with all of us together, with the wonderful leadership at the ministry, my recent secretary, my colleague, Mr. Manoj Jhalani, with partners who are so dedicated, who are so spirited, I'm sure we should be able to achieve MDG goal 4 and 5 in the next 500 days. Friends, I'll stop short here. I'm going to stay here till lunch or so. I would like to interact more with you. But thank you so much for your patient hearing.
Thank you, sir, for this very comprehensive account tracing this entire journey of igniting change. And though we started on a very grim situation, and these challenges, in fact, multiplied with the population increasing, but then with the concentrated effort, with a very dedicated and very structured approach towards it, the Government of India has been able to make a change, and that was visible in the stats which were shared. But at the same time, as he mentioned, there is a lot of key areas of concern which we need to focus, key states where the focus has to be on, and he also shared with us which is the way forward towards addressing these challenges which are presently there. Now, towards this, of course, there have to be policies and guidelines which can bring about the effective implementation of this entire plan. So to share with us now the galvanized policy actions by the Government of India towards the RMNCH+A, I would like to invite Mr. Manoj Jhalani, Joint Secretary Policy, for his presentation.
No. Morning, friends. Additional Secretary and Mission Director, Mr. C.K. Mishra sir. Dr. Rakesh Kumar, Mr. John Bede, Dr. Bulbul Sood, Madam Patricia Taylor, Dr. Rajesh Singh, and my friends on this side of the dais. Now, Dr. Rakesh has spoken really very comprehensively, leaving little room for anyone else to add anything on what he has said. I mean, it was a very comprehensive presentation, capturing the entire journey, capturing what our MNCH approach is all about, and also sharing areas of concern. So, when I was, I don't have any presentation, but as I was hearing Rakesh in terms of his journey, I was trying to recall my childhood. And as a child, I remember, when you used to go and touch the feet of your elders, the general blessing used to be, Jeete Raho. And I could imagine, if you have a very high infant and child mortality rate, or so many children, he said 50% children used to die, 50% of mortality used to take place before age of 10, I'm not surprised that the Ashirwad used to be Jeete Raho, which means continue to live. And now I see a change in terms of when you children seek the blessings of the elders, they say Khush Raho. So from Jeete Raho to Khush Raho, that has been the change over the years, and I'm sure this would effectively get translated in our achieving the MDG goals of both maternal mortality and the child mortality. And as I also, the focus, while certainly being there in terms of ensuring maternal and child survival, also on maternal and child well-being and maternal and child, child development to child's fullest potential, which is evident in terms of all the interventions like RBSK and others, RKSK, etc. Now, from the call to action at Mahabalipuram, we have really seen tremendous strides, tremendous energy, tremendous progress, a lot of things happening. We came out with this RMNCH+A approach, which really brought about the criticality that these individual pillars of family planning or child health or maternal health or newborn care and adolescent health need not be independent silos, but they have to be a convergent and simultaneous action on each of these pillars to really get the desired outcomes. And I'm also happy that in terms of tools and all, we came up with 5x5 matrix supported by 2x5 matrix. So in a way, 7x5 matrix, you might say. I mean, the other 2x5 pertaining to health systems, etc. To really result in desired outcomes. And one is very happy to see that that 5x5 matrix thing really has percolated down and right down up to sub-health centers. During the field visit, one was happy to see that that's reached. So it really shows how quickly the states have taken it, absorbed it, and rolled it down. And that's credit to the approach and credit to the partnership. I mean, the unique thing about RMNCH+A, besides this approach, was in terms of how we could create partnerships, not only between the governments at the center and the states, but also with a lot of development partners, and then harmonizing the efforts of all the development partners, and then further refining the approach in terms of focusing on those high priority districts wherein if we are able to effectively implement this approach, we will be able to bring about sharper reduction, sharper improvements in maternal and child health outcomes, and also ensure equity. So both from the perspective of ensuring sharper improvements and also to address equity, that focus on high priority districts with getting all the lead partners whose efforts were aligned and harmonized, and all of them simultaneously working on this RMNCH+A approach in those high priority districts. And I think that approach has to be carried forward not only to high priority districts, but also to high priority talukas or high priority blocks, or even panchayats for that matter. I won't go in any great detail on why it's all important, but the areas of concern, as Dr. Rakesh pointed out, one is the issue of quality. Not that one has not emphasized enough on terms of quality in that entire approach, but we have a long way to go. The second approach is, while, I mean, when we were entering this place, and I saw a lot of good publications of how best practices in various states and with pictures and real life stories, but the challenge is to really scale it up. Now, when you look in terms of the total data, in terms of our performance of health facilities, you realize that a major chunk, I mean, if you exclude the sub-health centers, which I'm not focusing now, but even amongst PHCs, CHCs and district hospital, it is almost 20% of the facilities which are bearing a disproportionate burden. So you have very good service, very good delivery of services happening in about 20% of facilities, but large part of 80% facilities still you do not see those interventions, you do not see the quality in those interventions. So the challenge is to really scale up those best practices across the state, across the country, and certainly in those high priority districts and high priority blocks. It's very cold here. Refrigeration. The other thing is in terms of trying to, you have heard about National Health Assurance Mission. The government is actively working on it. RMNCH+A related services would certainly form an integral part of it. But ultimately, the way we have evolved over the years, when NRHM came, although it was supposed to be a health system strengthening program, and where we would, strengthen the facilities to be able to provide a whole range of services, assured services, and also some kind of desirable services to raise the facilities to IPHS standards. But we are a long way off, and in reality, it has been more like an RCH+. So the health systems have been more like an appendage to RCH, and I receive, caustic remarks from my colleagues who handle NCDs and all that. You are only RCH centric, and you're not strengthening health systems to be able to cater to whole range of communicable and non-communicable diseases. So we realize it's important. So we would be working on strengthening both these facilities as platforms for providing integrated range of services beyond RCH. And it's important that health systems get strengthened to be able to support. They provide the platform to support a whole range of services, including, and very importantly, the RMNCH+A related services. I would compliment MCHIP and all development partners for providing excellent partnership or excellent technical support, and we would urge all the state governments and all the development partners to work with renewed vigor, energy to ensure that we are really able to bend the curve and able to show much sharper reduction and much sharper improvements in maternal and child health outcomes. Thank you so much.
Thank you, sir, for sharing your insights into the approach, and that was a very interesting observation of how this program has been able to make an impact on the change of blessings, as he shared with us. Now, ladies and gentlemen, United States, as many of you must be aware, it has been working in India. It has been supporting the various development programs of the Government of India, in fact, way back from since 1951. And as it was shared, this program has now enters the 6th year. This has been the longest running program of USAID. So we now request the views of Mr. John Bead, the USAID Mission Director, on further this partnership, and as he further extends the support and commitment to be working with the Government of India. Inviting Mr. John Bead.
Thank you very much. Additional Secretary Mishra, Joint Secretary Kumar, Joint Secretary Jalani, Dr. Sood, other distinguished members of the MCHIP team, colleagues, partners, friends, members of the Indian public health sector community here. I'm really delighted to have a chance to be here today with you for an event which really, for me, represents three things. It's a celebration. It's a celebration of the remarkable accomplishments that many of you have dedicated your entire lives to. It's also a celebration of India's ongoing and in many ways accelerating leadership role in the field of global health worldwide. And as we saw in Dr. Kumar's presentation, it's a chance to also draw lessons from each other. to learn from each other and look at areas that even as we celebrate and acknowledge, identify areas where we can do even more. And then finally, it's a reaffirmation of commitment. It's a commitment of USAID to continue to partner with the government of India, the private sector and civil society here on this very important endeavor and field of maternal child health care. And it's also a chance for this community of partners really to reaffirm our commitment very, very neatly and very, I think, powerfully expressed in the global call to action. At USAID, we've been very, very honored and I think fortunate to over a period of many years to partner with the government of India, civil society, private sector actors in so many different aspects of the public health arena. And we're especially honored now as we look to a new partnership, really, with India, that a partnership and cooperation that's not just having impact here in India in terms of helping to support the country's priority health initiatives, but really is having an impact on the global stage and is much more about not just kind of a reducing of India's global share of the health burden as was presented in so many areas, but it's really increasing India's share of finding global solutions to public health challenges, which is reflected obviously in the global call to action, which India and the United States lead on, but also you see it in many other very important health areas, such as HIV/AIDS, where the country's remarkable achievements in terms of dramatically reducing HIV incidence and prevalence is now being shared with other high prevalence countries. Today, when we talk about celebration and we talk about lessons learned, this is really an opportunity to hear from partners about kind of what's worked and what's worked well and what needs more attention. I think in terms of being a celebration, I really want to commend and congratulate the MCHIP team and its community of partners, which I think, as has been acknowledged, has really been successful in terms of providing timely and high-quality technical support. And that's a commitment that that is especially important here, given the government of India's priorities in the health field. Obviously, not just USAID, other development partners and the entire global public health community, we really are very much in awe of kind of what has happened over the last few years in terms of the development of not a program, as Joint Secretary Kumar pointed out, the RMNCH+A movement or initiative and concept, the dramatic rollout of that and the attention to increased accountability and the attention to trying to drive innovation and to reach parts of the country that still need higher quality of care. Not just the comprehensive nature of it, but the speed and intensity. I think for people who've been working in the public health arena can attest to that. It's really kind of a remarkable feat and continuity of effort that has taken place here. And in many ways, we're seeing not just a continuation of this kind of leadership to go beyond RMNCH+A, but in many ways a deepening. Earlier this year in June, the United States was very honored to receive the first visit of the Minister of Health and Family Welfare, Dr. Vardhan, to the United States, where he not only exchanged views on global health with his counterpart at the Secretary of Health and Human Services in the United States and other health leaders, but also co-hosted together with USAID and UNICEF the June acting on the call meeting. And I think I can speak for people who were there, the dozens of health ministers from around the world, our leadership, the development partner leadership, and other organizations that are playing a role on maternal child health care. Very struck by Dr. Vardhan's commitment, purpose, sense of vision, and really interest in deepening and going further on the call. And I think it was also particularly noteworthy in that we know it's not just words, because obviously Dr. Vardhan is not new to the public health leadership area, and obviously played a very important role in India's landmark achievement of eradicating polio. So when he talks about setting ambitious goals, he and his colleagues and team at the Ministry of Health and Family Welfare, it's not just talk. We've seen what can happen in polio, HIV/AIDS, and immunizations in so many areas, including the progress that's been made on the RMNCH+A initiative. So I think in many ways the stars are kind of aligned in terms of the kind of commitment and leadership we have here. I think the energy and the attendant commitment of the development partner community to support these initiatives, and this kind of commitment is going to be extremely important if we're going to maintain momentum. I would like to take the opportunity to really thank all of the people who played such an important role on the MCHIP. This does mark a bit of a transition to kind of a new set of partners in some ways. In other ways, many of the key organizations and people that have been involved in supporting the government of India's initiatives here will continue to be so. USAID will continue to support this effort very strongly, but we're very pleased to announce the addition of a respected Indian consulting firm, IPE Global, which will be working with JPEGO, John Snow, Save the Children, and many others as well to support this Indian initiative. Finally, I would be a little bit remiss if I didn't mark another transition, a bit of a bittersweet one for those of us at USAID. We were very unfortunate to lose a key member of our public health team, Dr. Sanjay Kapoor, but luckily he's not going very far, and he's going to stay very engaged on this effort, working with another one of our partners here, and will be instrumental, no doubt, in another capacity for some time to come. But we want to thank Sanjay for all his work here, in addition to celebrating the broader achievements. So I want to thank the organizers and the MCHIP team once again, and we very much look forward to deepening and in some cases broadening our partnership with the government of India. Thank you very much.
Thank you, sir, for sharing your views and perspective on the program and extending that satisfaction towards the growth and the evolvement of the program, and for that commitment also. Thank you. And may I now invite Mr. C.K. Mishra, Additional Secretary and Mission Director, National Health Mission, for his views and opinion. Inviting you, sir, for your inaugural address.
Thank you. Mr. John Beed, Mr. Manoj Jalani, Dr. Rakesh Kumar, Dr. Bulbul Sood, Ms. Patricia Taylor, Dr. Rajesh Singh, all the development partners present here, experts, and most of all, the concerned and committed stakeholders who are part of this movement, if I may say so. It's always a pleasure to be a part of such discussion where people who know people who are concerned and people who are committed are trying to get together to launch a movement on something that is so very important if we want to sustain even the basic healthcare system in the country. So thank you very much. Mr. John Bede spoke of celebrations. To be honest, I really don't know if we are ready enough today to celebrate the success of our strategy. But one thing that we must celebrate with a lot of satisfaction is the partnership. And it is this partnership which is going to stand us in good stead in the times to come. And thank you all for being with Government of India. And Government of India, in fact, is fortunate to have all of you on board to run a program that is not, these major health issues cannot be concern of a particular country. Or rather, they should not be the concern of a specific country. And we all do need to get together, and we are fortunate that we are. Dr. Rakesh Kumar has already given you a background of whatever had to happen, the journey that we have undertaken, the successes that we have scored, the problems that we've faced, and the challenges that we have before us. Dr. Bulbul Sood has given you a background. So permit me, if you may, not to get into these issues because you all know what RMNCH+A is and the way the initiative has been framed. Let me first and foremost thank the organizers for this event, thank the development partners for conceiving this, and also I must mention my predecessor, Ms. Anuradha Gupta, for taking this initiative and launching this program in this country. This now will remain our focus. If you look at the focus of Government of India in the healthcare delivery system in the country, we are essentially looking at a scenario where we want to provide accessible, affordable, quality healthcare services. And I always want to add one word to that, and that is sustainable healthcare system. Within that, we have a huge concern of prevention of maternal and child death. We would ideally like to reach a situation where every child who is born lives a decent, dignified, happy life. And every mother who gives birth lives to see the child grow to his potential and lead a happy life. And Manoj may recoin his entire thing as Khushi ke saath jiyo. That is the basic purpose and focus of what we want to do for this program. Actually, we all know what the problem is. You also know what the solution is. We are faced with a task of actually getting that solution to the field and getting results out of it. If you ask me, the challenge is not so much in the program, the challenge is not so much in the concepts. The challenge is where it should actually be implemented. And that is the challenge we should face head on and find solutions to it. You see, the way NRHM has grown, and Manoj talked about it, even if we are totally focused on RCH today, we need a strong, robust platform to implement what we want to. For this, we need very, very strong facilities across the country. Therefore, the strengthening and implementation of RCH must go hand in hand in this country. And that is why we must resolve to prevent every maternal and child health. It can be done, and therefore, it must be done. We've all been working very hard all these years. It's a collective concern, and therefore we've come out with a collective response to it. And when the program implementation is a challenge in this country, it's for two basic reasons, which many people outside this country often fail to appreciate. One of the basic reasons is the sheer numbers. It's a daunting task. As if that was not enough, we are working in a situation where every region of this country is different from the other. So the challenges get compounded, and our responses cannot be uniform across the country. So we have to work out strategies in different areas to retain high quality interventions in our program. And therefore, the importance of all the development partners having taken over different areas in the country to provide technical assistance and to join hands with our health workers down the line to actually see successful implementation of our programs. We are all aware that RMNCH+A was a response to the global call. There are three things I feel which are of vital importance as far as this program is concerned. First is that we are moving out of our vertical silos to put the program together in an integrated way. Second, that we have some amount of focus. Focus in terms of geography, when we talk about high priority districts in the country, and focus in terms of implementation when we talk about our 5x5 metrics plus the 2. So this kind of a focused approach is the only way which can help us take this initiative forward. While we are working on this program, we need to really think as to where we are and where we need to be. One of the basic issues is, even with all the interventions that we have made in the field, the level of the confidence of the beneficiary today is still low. We have not been able to inspire enough confidence in the person that we not only just care, we can actually manage. So it is this management skill which we really need to develop and put down. It's a long journey ahead. Unless we take on board all these people who are in the field and who expect a quality delivery, healthcare delivery from us, we will not succeed in this program. We have successfully brought down the numbers year after year, as the presentation shows. But when you look at the global scenario, we are far from where we should be. Our frontline workers are in many ways dedicated workers. But the focused delivery that should have happened is not happening because the tools that they are using are not the most appropriate tools for the area that they are working in. What I am trying to say is that I look at still a larger scope of focusing and fine-tuning our programmatic approach when we come to this whole huge program of prevention of maternal and child death. That is where I seek a stronger partnership. That is where I seek more technical assistance so that we are able to evolve a program which is basic, which is simple, and which is focused and effective. We spoke about the documentation we have done, the SOPs that we have put in place, the number of guidelines that we have issued. We need to also pause for a moment and think. These guidelines and all these documents are extremely effective if the person who is using them goes through them carefully and actually follows them. I do not want to sound discouraging in any way, but let us face facts that these are issues we need to attend to very seriously. What is the best way of getting to a person a program which is able to attract his attention in a way that he understands it in the simplest possible way? That is the kind of language we should be speaking to them when we talk about the program implementation in the field. Mercifully and thankfully, we are now in the process of integration of various vertical programs that we were running. All this creates confusion. The aim and objective of majority of the programs that we are running under the National Health Mission is the same. But we are approaching things in different way, and there are different people who are working differently from different sides. We need to put all this together. It's not an easy job. It's very easy for me to be standing here and saying all this, but it's not an easy job. But the sooner we are able to get even halfway in this, the better results we'll be able to get. But what actually stands behind all this and what is of great satisfaction is that in the last couple of years, we've now had an approach which unites people, unites program implementers, unites ideas. Therefore, if we can move this forward in a way which is simple and effective, we will see the results. India, being so vast, we need to do things a little differently. It's not for the first time that in the country we have shown concern for maternal and child health. What is so different about it? What is different about it is that we are now focusing on programs which straight hit on this. Therefore, I am extremely happy that we've reached this stage. I am extremely happy that we have a commitment to work together and move on in this direction. And hopefully, very soon, we will see the results also coming. As long as we are able, as Rakesh spoke, that there's Bihar, UP contribute to more than 50% of the problem, therefore our focus should be Bihar and UP. Unless we improve indicators from such states, we will not be able to improve national indicators. Therefore, it's a good plan to have a focused area approach, and we need to move on with this. I would not like to say very much on this occasion, because this I took as an opportunity to thank everyone for the participation and the continued commitment. I would just say that let us try and build a program which is a focused program based on our learnings and evidences that we have got during our learnings. B, let us run a differential program which caters to specific need of geographies, caters to specific need of the people of that area. C, let us run a neutral program which takes into consideration the cultural values of the people we are going to communicate with, we are going to interact with, and for whom we are working. And last of all, let us work on a program which is implementable. If we can do this, I think half the story is on our side, and I am confident with the team that I have in the ministry and all of you putting your entire weight with us, we will see the success. And there is no scope of despondency. We need to be very optimistic about where we are going and reassure ourselves that what we have set out to do, we will do and achieve. Thank you very much, ladies and gentlemen. Thank you for giving this up.
Thank you, sir, for your very thoughtful address, in fact, very thought-provoking address also. And as you mentioned about that the need is now more on focus and implementation, communicative and being a people-oriented approach. We have the release of the 2 photo books and the DVD right now. May I request Mr. C.K. Mishra to kindly do the honors of the release. There are 2 photo books which are now going to be released and a DVD which contains 10 videos. May I request you, sir, to kindly probably stand here in the center. Probably you can do that. So there are 2 photo books which are going to be released now. And as I mentioned, there is a DVD which has 10 videos. The first photo book is entitled Empowering Women with Family Planning. MCHIP has played a vital role in contributing to the Government of India's efforts towards promoting healthy timing and spacing of pregnancies, along with prioritizing provision of quality family planning services. MCHIP provided focused technical assistance in the states of Uttar Pradesh, Uttarakhand and Jharkhand. And this photo book focuses on the work which has been done in India by MCHIP in the areas of postpartum family planning. It is an attempt to highlight the human impact of its winning strategies through pictures, stories and testimonials. The second photo book, which is now being released, is Opening Doors to Quality Education. This is a collection of exquisite photographs that takes the readers through MCHIP's journey of strengthening pre-service education for nurses and midwives in India. With exclusive anecdotes from stakeholders and beneficiaries, this book is a way to look at the various components of the intervention. The photographs give life and face to the efforts made in this area. And we now have the release of the DVD. This DVD has 10 videos. I'll just quickly introduce you to the 10 videos which are there in that. Empowering Women with Family Planning, Voices from the Field. There's a video on Kusum Munal. She's a confident nurse in making from Uttarakhand. The story highlights the impact of MCHIP's work in strengthening pre-service education of nurses and midwives in India. The third video is Saving Lives in Remote Jharkhand, the story of one of the 885 nurses trained by MCHIP. The fourth video is the story of Seema, a mother of 3 living in an urban slum of Dehradun, Uttarakhand. The story tells about how her life has been bettered and how she's able to better with the others. Next is the Healthy Mothers, Healthy Children, Healthy India. Some of these videos we are going to be showing you in the day.